Good morning, everybody.
Good morning. How are you today?
I'm doing all right. How about yourself?
I'm doing just dandy.
Okie dokie. Well, we'll go ahead and thank you, Sophia. I got my first haircut in 13 and a half months. So it feels really good to have all the dead hair off. So getting the vaccine opens all kinds of doors. So thank you. Yes, this is what happens when my stylist straightens it for me. So I always love when I can get that done. She's very sweet. I've been going to the same stylist for about 10 years. And the day before I called, apparently she was telling the staff, like, call Taryn and see how she's doing. So I thought that was really sweet, where she could have just assumed I dropped off the radar. So it's nice to have those types of relationships. Alrighty, so today we are going to finish the sexual dysfunctions and then the paraphilias, and we'll talk very briefly about gender dysphoria, and then we'll start schizophrenia today, and we'll finish schizophrenia Thursday. Exam 3 is 1 week from today, and that'll be the exact same format all the other ones have been, so hopefully y'all did so much better last time than the first one that I think you've got the system now and you'll do really well on it. Make sure you are doing the clinical choices, because again, the short answer is going to refer to those. It's sort of an automatic 5 points off if you don't have those. Also, they'll just help you study. There's some really good videos in there and ways of thinking through the symptoms of these disorders and whatnot. So we really made an effort to do that when we constructed those. So I hope you're enjoying those. I had a lot of fun making them, actually. So hopefully you all enjoy doing them. I think that's it in terms of like stuff that's going down. Just reminder, if you haven't met with your advisor yet and you're continuing next year, make sure that you do that so that you can get registered, because registration is opening today. I believe is seniors, people of senior status who need like another semester or two, and then tomorrow is anyone with junior status, which I think is a decent chunk of y'all. So alrighty, I'm gonna go ahead and stand up here. Get this adjusted so you can actually see me, and reopen our PowerPoint. I don't know if anyone else has enjoyed this feature that PowerPoint now has. I think it's had it for the past couple of years, but it'll just say things like, do you want to go to the slide where you left off? Just like, sure, that's great that you remember that for me. Alrighty, so I am going to go ahead and share screen. Okay, so we were talking about the sexual dysfunctions, and in particular, we were just starting to get into how do you treat these, right? So these are things that like could have some sort of physical component, but mostly are psychological, which is why they're in the DSM, right? So, one of the things we emphasize is that you want to refer them for sort of a workup if you think there is anything physical going on, or just to sort of rule it out, honestly. But in terms of what could you do psychologically, well, these are the general things that we do in modern sex therapy. So I think I might have done this slide last time, but I'm going to go over it again just because I think I rushed through it. So modern sex therapy tends to be very short, interactive, 15 to 20-minute sessions, so much shorter than the typical 45 to 50-minute therapy session. It's centered on specific sexual problems. You don't like go into all their personality issues unless it's somehow directly relevant. So you want to assess and conceptualize the problem. You take a sex history, and again, often refer them for medical tests. Then talking about both partners sharing in responsibility for the problem. Educating them about sexuality and sexual pleasure. Unfortunately, this is something we never learn about in sex ed, no matter how good it is usually, right? So things like, the vast majority of female orgasms have to involve the clitoris, right? Like most people don't know that. So attitude change. So challenging myths that exist, like all touching is sexual and should lead to sex. Like it's okay to just cuddle sometimes, right? And then elimination of that performance anxiety and the spectator role we were talking about. So if you remember, this is where you feel like you're kind of watching yourself, and then you have so much anxiety about like, is sex gonna go well, that anxiety itself actually interferes. It's actually, my daughter got this adorable little book called Ruby Finds a Worry. It's about anxiety for kids. And one of the things I talk about is like, the worst thing to do for a worry is to worry about it, right? So this is sort of that like worrying about it makes it much, much worse. So part of what they do there is what's called non-demand pleasuring. We'll talk about that in more detail in some of our other slides today. They want to increase general communication skills, so telling your partner what you like in bed, but also just like communicating throughout the day. Changing destructive lifestyles and marital interactions. So these would be things more in the relationship in general. So if you have people who are passive aggressive to each other, things along those lines, like that's going to translate into the bedroom and make things more difficult. And then again, addressing those physical and medical factors. All right, so the disorders of desire would have some more specific treatments here. So these are the most difficult to treat because many of the issues that feed into them are pretty complex. So therapists try to apply a combination of techniques, including things like affectual awareness. This is like awareness of what emotions you're experiencing. A lot of people are really bad at this. And it's like not only to sexual dysfunctions, but to things like depression, anxiety, disordered eating. Self-instruction training. So getting them to masturbate and figure out what works for them. Behavioral techniques, exposure for things, the working up any sort of hierarchy that exists, maybe doing some relaxation training if there is anxiety here, insight-oriented exercises, helping the person to explore, is like sexual desire that important to me, right? And if it is, what's getting in the way of it? And if it's not, then like maybe I'm asexual or aromantic and that's okay, right? For some people who do have physical things going on, they might require biological interventions such as hormone treatments. For erectile issues, these focus on reducing men's performance anxiety and or increasing stimulation. So this can include sensate focus exercises. It's kind of like mindfulness, but for sexual pleasure, sort of paying attention to what makes you feel good. And then there's also what's called the tease technique, where you can sort of get yourself ramped up and then like wait so that you get used to sustaining that sexual arousal. Biological approaches are probably the most common here. So Viagra is the most commonly used med, but certainly there are other ones that we see advertised, right? Um, and these are used when it has biological causes, and these have a lot of momentum, maybe not surprisingly. But there's other biological approaches that have been around for decades, and these include things like gels, suppositories, penile injections. There's a penis pump, essentially, that the technical term is a vacuum erection device. There's also, if you are just having long-term physical problems or you have some sort of neurological issues, again, these are things we talk about with clients on the spinal cord injury unit, right? So if you have like a C4, C5 injury, it's just not going to physically ever go up by itself, right? So you can actually get a penile implant installed that allows you to determine when you get an erection. Male or
Can I ask something real quickly? And
Sure,
just since
sure.
this is abnormal psych, I hope this doesn't sound weird. How do you control the implant?
I believe there's like a button. So I don't know how much people are familiar with other types of surgery. So like when we were talking about the like deep brain stimulation, that there might be like a port where you can do things.
Right.
Gastric banding, like the lap band, some of you may have heard of that. They actually put a port under your skin where the doctor can increase or decrease the amount of silicone in there, and that, or saline, sorry, you don't want silicone in there, and that can tighten or loosen it. So yeah, they have ways where essentially there would be a way you could control it. I haven't looked into this probably in 10 years. At this point, we're so advanced, they may have a remote control. I don't know, honestly, it'd be interesting.
Exactly, right.
I mean, it's almost, sci-fi in what we can do now, which obviously is great for people that this is an important part of their life they don't want to miss out on because of physical limitations. But yeah, that's a great question, Charleston. Yeah, it's sort of weird to think about, like, there are things that we can put in our bodies that we can control from the outside, right? Definitely.
Thank you for being willing to answer that. I know that was weird.
Yeah, and again,
I was confused.
I don't know how it works now. They probably have much more advanced technology, I would guess. Great question. All righty. So yeah, that's erectile disorder. And then orgasmic disorders, particularly if you have that early ejaculation or premature ejaculation, they're going to include techniques to reduce that performance anxiety, increase stimulation as needed. And when the cause of disorder is physical, and when this is like delayed orgasm, delayed ejaculation, they may include a medication to increase arousal of the nervous system so that you're more tuned into those sensations. And again, especially if there are physical things going on. All right, so for early ejaculation, one of the ways we treat this premature ejaculation is by behavioral procedures, the start, stop, or the squeeze techniques. And both involve bringing the man to arousal, then stopping before ejaculation, and then repeating that process so that they experience stimulation for longer than before. This would typically be done by the man and his partner, outside of the session. There are some sex therapists who do behavioral things with their people in session, but it's very clinical at that point. So think about, women, if you've ever been to the OBGYN, or, men, if you've ever been to the proctologist, right? Like these are sort of like medical procedures at that point. And so after 2 to 3 months of working on these techniques, it can actually lead to prolonged intercourse without any sort of medical intervention in terms of medication or anything like that. Some clinicians, though, will use Prozac or other SSRIs because these drugs often reduce sexual arousal or orgasm as a side effect. They can be used here, essentially. Some studies have reported positive findings with that, but like long-term outcome studies of like having someone on an antidepressant when they don't need to be really need to be done. And then for the female orgasmic disorders, self-exploration is a big one. A lot of women have never masturbated, so encouraging them to go home, explore things. A technique might just be to hold a mirror up and look at your genitals and see what's where, because a lot of people have never done that. You know, I forget what the percentages, I said it at the beginning last week, but like there are a good percentage of women who've never had an orgasm, right? So then to just spontaneously expect they could have one with a partner isn't that realistic. So teaching them body awareness and directed masturbation training would include things like, here's how you masturbate, like go home and do this. And again, it sounds a little silly, but if you've never done that, and particularly if you come from a culture or a religious background that teaches you that's like a sin or dirty, right, you need some help around that. Another thing to notice is that a lack of orgasm during intercourse is not necessarily a sexual dysfunction, again, provided the woman enjoys intercourse and can orgasm in other means. Most women can't orgasm without some sort of clitoral stimulation. So if that's not happening during intercourse, they're going to need to find other means. So for this reason, some therapists believe the wisest course of action is simply to educate women whose only concern is lack of orgasm during intercourse. So educate them about all the other ways you can come to orgasm, basically. All right, so Masters and Johnson, again, were sort of revolutionary in their time, thinking about how do we treat folks? What are the sexual dysfunctions? How does sexual behavior work? What are the physiological effects on the body? So they actually would do things like videotape their outward expressions. They devised a camera so that they could actually insert it vaginally and see what happened during a female orgasm, because no one had done that before. But we've really expanded beyond what they came up with. So it used to be that they would only treat married couples. And now we'll treat unmarried couples, people with psychological disorders, people who have severe marital discord, the elderly, the medically ill, the physically handicapped, clients with different sexual orientations, and clients that don't have a long-term sex partner. Like basically we don't restrict who has access to this therapy now. I mean, it used to be that even information about this was limited. So Kinsey, who is another well-known sex researcher, when he taught a class about the sexual response cycle, only married students were allowed to take it. So again, we've come pretty far since then, right? Therapists are also paying more attention to excessive sexuality, which again is not a diagnosis, but is a thing. So I hope that eventually the DSM will include it. Essentially sex addiction, or some people consider it like a impulse control disorder. And the use of medications to treat sexual dysfunction can be troubling to some therapists. They're concerned that rather than doing an integrated approach that'll really help in the long run, people are going to just sort of go to the medication. And I think, as I mentioned on Tuesday, you have to be really careful when you're prescribing Viagra because it can interact with some heart medications. And let's say you go to the ER and you are having chest pains and you've taken Viagra that day and you're embarrassed, so you don't tell them, right? They can inadvertently give you something that'll have a really bad interaction. So I knew of psychiatry residents who basically told their clients, like, you have to not be shy about this. You have to be open about the fact that this is one of your prescriptions, because otherwise it can really affect your life, even potentially result in death. All right, so now we're going to move to the paraphilias. And these are completely different, to be perfectly honest, in their nature than the other sexual dysfunctions. Paraphilias are disorders characterized by unusual fantasies or sexual urges or behaviors that are recurrent and sexually arousing. They can involve things like humiliation of the self or their partner, children or other non-consenting people or non-human objects. So according to the DSM, these should only be diagnosed when the urges, fantasies, or behaviors last at least 6 months. For most paraphilias, these behaviors must also cause distress or impairment, right? So if you are into humiliation or pain with sex, but you're not disturbed by it and your partner's okay with it, and you have safe words, right? That's not a paraphilia, right? It's just if it's disturbing to you. There are some differences, however. Certain paraphilias, performance of the behavior itself is indicative of disorders. The clearest example here is pedophilia. So we don't say, you know, that that's an okay thing and people just don't understand, like, no, right? That is not okay. That is illegal. That is ridiculously damaging to children. And so it's a disorder whether it disturbs you or not. Some people who have one kind of paraphilia will display other types of paraphilias as well. Relatively few people receive a formal diagnosis because relatively few people will seek treatment for these. Either they're embarrassed or they're not distressed enough to seek treatment. And clinicians do believe that the patterns may be quite common, but again, that people are too embarrassed to seek treatment, or again, some people just might not be disturbed by them, and then it's not a paraphilia. Although therapists have proposed and theorists have proposed various explanations for paraphilias, there's little formal evidence to support these theories, partially because it's so hard to get samples, right? People are just not willing to like sign up for a study about your paraphilia. There's a lot of potential stigma, et cetera, that can go along with that. None of the treatments applied to paraphilias have received much research or have been proven very clearly effective. There are some behavioral things that will work for certain paraphilias. But in general, we don't have a laundry list of empirically supported therapies like we do for eating disorders or depression or anxiety. Psychological and sociocultural treatments have been available the longest, but we also have some biological interventions that can be used now. All right, so this is like the overarching diagnosis, and then each one has its more specific criteria, but this is like for a paraphilic disorder in general. This is what we're looking at. So again, has to last at least 6 months. Can't be just like a one-time, wonder what that would be like. So the person experiences recurrent and intense sexually arousing fantasies, urges, and behaviors involving, it can be objects or situations that are outside the usual sexual norms. So non-human objects, non-genital body parts. So this is where like foot fetishes would come into play. Suffering or humiliation of oneself or one's partner or children or other non-consenting persons. And then again, significant distress or impairments over those fantasies, urges, or behaviors. And then it does specify some paraphilic disorders: pedophilic disorder, exhibitionistic disorder, voyeuristic disorder, frotteuristic disorder, sexual sadism disorder. We're going to go into detail about what each of those are. It means you have the disorder even if you're not disturbed by it, because you're violating other people's rights, essentially. All right, so we'll start with fetishistic disorder. And this used to just be called fetishism, and then they changed it to fetishistic disorder, and this is paraphilic disorder is the pattern of language they use in the DSM-5. I think, again, to make it more clinical and less of like a stigmatizing label, if that makes sense. So the key features of fetishistic disorder involve intense, recurrent sexual urges, sexually arousing fantasies, or behaviors that involve the use of a non-living object. This disorder usually begins in adolescence, and almost anything can be a fetish. One that's really common people think of is like shoes, right? Can be like specific to high heels or boots or something like that. So psychodynamic theorists view fetishes as defense mechanism, but therapy using the psychodynamic model has been unsuccessful. Behaviorists propose that fetishes are learned through classical conditioning. So we're back to like the Pavlov dog idea. So that maybe at some point when you were sexually aroused, you saw a shoe and somehow that got associated in your mind, right? Like the bell for the food for the dogs. So the way that they are treated can be a whole host of behavioral things. So one is aversion therapy. So this could be applying a electric shock, not enough to like damage the person, but enough to, you're paying attention, right? Make it aversive when you imagine or look at a picture of your object of desire. Covert sensitization would be pairing the object of your desire with an imagined aversive stimulus. So rather than getting a physical thing, you would imagine something. So when I teach my clinical psychology course, there's a case study in there of a man who does have pedophilic disorder, and they make him imagine throwing up every time he imagines young girls. So something like that can really work as well. Another behavioral treatment is masturbatory satiation, which basically you have the person either look at or imagine the fetish object and masturbate until they're bored, basically taking away that sexual desire of it. Additional behavioral treatment is orgasmic reorientation, a process which teaches individuals to respond to more appropriate sources of sexual stimulation. But again, if the person is not disturbed by this and they're not like engaging in anything illegal to get the non-living objects, right? You know, they're not going and stealing shoes, right? This doesn't have to be a disorder if the person's not disturbed by it.
I have a question.
Sure.
Because, of course, you know how we used to consider homosexuality a paraphilia, and they used to apply these kinds of treatments, and they obviously didn't work because it's not an illness. But do they actually work for people who have paraphilias, or?
That's a good question. So for things like objects, yes. For things like pedophilia, not at all. Yeah, so there are some things that it seems like are just so ingrained that it just doesn't work that well. One of the ways they actually, I don't think I have this on the slide, one of the ways they actually used to treat homosexuality and like is still used to treat pedophilic disorder today is chemical castration. So they basically give you a cocktail of pills to take that take away all your sexual desire. That's actually what they did to, I forget his name and I feel awful, Benedict Cumberbatch played him in the movie. But the scientists who came up with the Enigma machine, which they used in World War II to decode Nazi messages, and they were actually able to, that was a big part of what helped us win World War II, was the fact that we can now know what the Nazis were going to be doing. But the man who actually developed that machine was gay, and they chemically castrated him after everything he did. Yes, The Imitation Game is the name of the movie. It's amazing. It's a really good movie. And he unfortunately committed suicide as a result. So what a thank you for this guy who helped us win World War II. But yes, so there are ways that work. How ethical they are, right, becomes part of the issue. Typically with something where it is going to violate someone else's rights, the only way we can treat it is for some time. I mean, just getting them away from people that they can harm. But yeah, that's a really good question, Romina. Yeah, and there are some cases where that's worked for pedophilic disorder, where the behavioral things do work, but there are other cases where it just doesn't. And so I'm not really sure.
Okay, thank you.
If I think of that, right? There are some therapies that just don't work for some people. All right, any other questions about that? Because that's a really good line of questioning. Awesome. Okay. All right, so transvestic disorder, this is confused sometimes with being trans. It is not being trans, okay? But this is where some of the stigma associated with trans individuals comes into play. Transvestic disorder, or basically being aroused by cross-dressing. It's characterized by fantasies, urges, or behaviors involving dressing in the clothes of the opposite sex in order to achieve sexual arousal. So this is really different than someone who is trans and believes that they are just inhabiting the wrong type of body, right? So for someone who's trans, it is not a sexual thing at all, right? But there are people, and again, like, if this is your kink, this is your thing, and it doesn't distress you and you're not like harming anybody else with it, go on with your bad self, like the Rocky Horror Picture Show, right? But if, you know, this is distressing to you, again, we can try to help folks out. The typical person with this disorder tends to be a heterosexual male who begins cross-dressing in childhood or adolescence, and again, for sexual purposes. And the development of the disorder seems to follow the behavioral principles of operant conditioning, where cross-dressing is somehow reinforced, often by the sexual pleasure, or maybe by how sexual partners respond to it. Okay, so then exhibitionistic disorder. This is one of those disorders that if you have this, it doesn't matter if you're distressed by it because you're violating other people's rights. So this is characterized by arousal from the exposure of your genitals in a public setting. So this is flashing. And sexual contact here is neither initiated or often not desired. It is honestly the power of flashing someone turns these people on, knowing the other person really can't do anything about it. This begins before the age of 18. It's not common in general, but it occurs more often in males. Treatment generally here includes the aversion therapy and masturbatory satiation, but you can combine just basic social skills training, right? So like if you want some attention, here's how you have a conversation instead of, flashing them. Psychodynamic therapy sometimes is used, or that orgasmic reorientation we've mentioned before. But again, this is illegal, so you can often run into the law with this. Actually, fun fact, I don't know if this is true during COVID, but I learned at one point that one of the most common causes for arrests on our campus is public nudity, or whatever it's called, indecent exposure, because people go and just like pee in the woods when they're drunk. So like, don't do that. Voyeuristic disorder is characterized by repeated and intense sexual desires to observe people in secret as they undress or to spy on couples having intercourse. And it may involve acting upon those desires. So you may actually have someone who's a stalker, or what we used to call a peeping Tom. They may masturbate while looking at the people, or while remembering it later. And the risk of discovery often adds to the excitement here. Again, this is another one where there's a whole host of associated criminal charges, right? So it could be like public indecency. It could be, stalking, right? So you may end up with legal issues because of this, and you don't have to be distressed to be diagnosed with this. But the risk of discovery adds to the excitement. Psychodynamic theorists propose that similar to exhibitionistic disorder, these people are seeking power. Others have viewed it as a attempt to reduce castration anxiety. Behaviorists explain it as a learned behavior that can be traced, again, like fetishistic disorder, operant conditioning, some sort of chance and secret observation of a sexually arousing scene, and so then they seek that out again. All right, Freuderistic disorder, or Freuderism, is yet another one that doesn't matter if you're distressed because you're violating someone else's rights. So a person who develops this disorder has fantasies, urges, or behaviors involving touching or rubbing against a non-consenting person. So this person with this disorder is almost always male, and they fantasize during the act that they are having a caring relationship with their victim. How extra sweet, creepy, right? Ooh. This usually begins in the teenage years, and they tend to decrease and disappear after the age of 25. But again, obviously can get you into legal trouble because this can, depending on where you're doing the touching, this can be considered sexual assault. All right, so now we're into pedophilic disorder. And one thing that I should say about this before I get started, I have always been really angered by this disorder, even before I had my daughter. Partially because when I was treating clients, a lot of the clients I saw who had disordered eating behaviors, who had PTSD, all other host of things, depression, serious anxiety disorders, had been abused as children, had been sexually assaulted or abused repeatedly as kids. And so I have seen the actual psychological consequences of that. And that's why this ticks me off so much, because it is so damaging to the children that experience it. So
Yeah, I'm sorry. I wanted to ask you, up to what point with things like pedophilia and fatherism are we pathologizing people who maybe just don't care about other people?
yeah, that's a really good point, Romina. And it's sort of like how much of this plays into like the same type of things that go into antisocial personality disorder, which we know we can't really treat, right? And if you're not familiar with that label, it's basically people we call psychopaths. Yeah, and I think that's a big part of this is just like these people don't care about other people or they don't have the empathy or what we call theory of mind to imagine how their behaviors could hurt other people. Yeah, I think that's a big piece of this is that these are people who don't care about other people and we've decided that's abnormal. And so we diagnose it. But yeah, should we just be not calling this any kind of mental illness and just saying like this is criminal? Maybe, right? I think that that's a good point. Here are one little fun fact. So I think I've explained about the DSM that is published by the American Psychiatric Association, not the American Psychological Association. And in the first printing of the DSM-5, they actually had a awful typo and called this a sexuality. And so, or like a sexual orientation instead of like a sexual deviance. This is not a sexual orientation. They corrected it soon. They issued a retraction, but it's like, how did people miss that, right? There are people in our society who try to claim that this is acceptable. There are organizations that try to claim this is acceptable. It is not. It is almost always going to result in at least one horrific consequence for the child. You know, even if they don't go on to full-blown PTSD, they're going to have all kinds of issues with trust, their body, things like that. But yes, I think, Romina, you bring up a really good point that like, these are just people who don't care about other people, right? And should we even be giving them almost the benefit of a diagnosis, right? So this is characterized by fantasies, urges, or behaviors involving sexual activity with a prepubescent child, usually 13 years of age or younger. And another side note, if you want to see if there are any of these folks around you, the National Sex Offender Registry is something you can Google, and it will actually show you where people who are sex offenders live. They're not all people who engaged in pedophilia, but it is sort of interesting to see that. So some people will kind of stop with child pornography. Not that that's great in any way, shape, or form, right? Others are driven to watching, fondling, or engaging in intercourse with children, raping children, let's be honest. And evidence suggests that 2/3 of the victims are female. So I think in the past, 10, 15 years, we've had a lot of attention around victims with pedophilic disorder, victims of childhood sexual abuse who are boys. And I think it's really good attention has been brought to them, right? So the victims of the Catholic Church or Jerry Sandusky, that type of thing. But 2/3 of the victims are female, and we're not hearing about them. And I think that's really important to keep in our mind and recognize that there are probably a lot of girls who don't report because they think they're not going to be believed.
Question for you.
Mhm.
In those situations, because I've seen, like, I think I did for a class one time, we had to look at different city background checks and look at, we were actually seeing who people were in areas that were registered. How quick is the government to move if someone is found innocent? Because you know how there could be cases that are long, drawn out, and then you kind of, they get reopened and all that good stuff. Is it a thing where as soon as you can prove that you were innocent, they'll immediately take you off? Or is this like a whole nother long process?
That's a really good question. I don't know the exact answer to that, but I'm guessing it's a whole nother long process, just knowing the bureaucracy of our government, honestly.
Right.
Yeah, and I mean, and this is why I always tell people, like, tell your, younger siblings or people who are still in high school, like, be really careful with sexting, because there are cases where people have been brought to trial for child pornography, for sending their own images. And then you're branded as a sex offender for the rest of your life. So, like, maybe just don't sext. Maybe there's a lot that can go wrong. I don't want to, like, shame anyone that does it, but, like, there's got to be safer ways we can do that stuff, right? So yeah, these are things that have really long-term consequences. But yeah, the government is very slow. The court proceeding, like Carlson said, is very slow to overturn those things. But we're also problematic the other way. So there have been multiple cities that just had warehouses sitting there of untested rape kits. And granted, not all of those are from children. But when they finally got to testing them, Virginia was one of these. Virginia had a backlog, and I think it took Mark Herring, who's our current attorney general, to actually start processing them. And I know in Detroit, when they finally processed these, they found several serial rapists, right? Or like the same perpetrator's DNA was in several rape kits. So like if they had tested that and actually pursued it at the time, they could have prevented a lot of crimes. So yeah, there's a lot of issues, both directions here. So in terms of specifiers, it can be either exclusive or non-exclusive sexual attraction to kids. So some people are attracted to adults as well. They can be sexually attracted to males, females, or both. And it can be limited to incest. And if you're not familiar with what the term incest means, it means within your family. And this is unfortunately one of the more common ways children are abused is by people they should trust. Their fathers, their uncles, what have you, sometimes their mothers. All right, this is not okay. I do have the wording of the retraction actually in here from the DSM-5. Sexual orientation is not a term used in this in the diagnostic criteria for pedophilic disorder, and its use in the DSM-5 text discussion is an error and should read sexual interest. In fact, the Little APA considers pedophilic disorder a paraphilia, not a sexual orientation. This error will be corrected in the electronic version of the DSM-5 and the next printing of the manual. APA stands firmly behind efforts to criminally prosecute those who sexually abuse and exploit children and adolescents. We also support continued efforts to develop treatments for those with pedophilic disorder with the goal of preventing future acts of abuse. Don't have any more comment than that. People with this disorder typically develop it in adolescence. Some of the folks who develop this were sexually abused themselves as children. So it becomes like normalized for them. That being said, I think a lot of people who are sexually abused themselves as kids go the opposite direction, right? Like they would never do that to a kid because they knew how it impacted them. Many were neglected, excessively punished, and deprived of close relationships in childhood. So it wasn't just sexual abuse, there were other types of abuse going on. Most are immature, display faulty thinking, and have an additional psychological disorder. So some theorists have proposed that there's a related biochemical or brain structure abnormality, but we haven't quite gotten there yet. Most people with pedophilic disorder are, when they're found out, imprisoned or forced into treatment. And here's where they'll use aversion therapy, masturbatory satiation, orgasmic reorientation. There's a version of CBT here that you can use that involves relapse prevention training. It's actually modeled after programs used for substance disorders. Again, none of these work that well. This is one of those disorders where it's really hard to convince the people that it's wrong.
Didn't they used to use shock therapy for this as well?
Yes, yeah, yep. So that's the aversion therapy. Yep.
Oh, okay. My apologies.
They still do it, but at one point they did it where they'd actually put a cuff around the penis and they would shock the person's penis while they looked at like a child porn image. I don't know if they still do that or if that's like totally unethical to them. All right, then we have sexual masochism and sexual sadism disorder. And so sexual masochism disorder is characterized by fantasies, urges, or behaviors involving the act or the thought of being humiliated, beaten, bound, or otherwise made to suffer. They believe that these begin in childhood and develop through behavioral process of classical conditioning. Again, somehow being punished is associated with sexual pleasure for that person. Sexual sadism, this person finds fantasies, urges, or behaviors involving the thought or act of psychological or physical suffering of a victim sexually exciting. So this is actually named for the infamous Marquis de Sade. So if you're familiar with his story, that makes sense. And people with sexual sadism imagine that they have total control over a sexual victim. Again, these may appear first in childhood, and the pattern is very long-term. And again, probably related to classical conditioning, although there may be some evidence of modeling here. They've seen other people do it. Psychodynamic and cognitive theorists view people with this disorder as having underlying feelings of sexual inadequacy. Biological studies have found possible abnormalities in the endocrine system. And the primary treatment here is aversion therapy. But again, if you have people who are into this type of thing and it's consensual and they're using safe words, right, there's actually no problem with it if they're not disturbed by it. So BDSM is not automatically a paraphilia. So that's really important to know. But, you know, if you're engaging in sexual sadism with unconsenting victims, it's like pedophilia, it's like fetishistic disorder. You're automatically considered having this disorder, whether it bothers you personally or not. All right, and this slide just says what I just said, basically. All right, so now we're going to talk about gender dysphoria, which used to be called gender identity disorder. So we have walked it back from being a disorder, and now we're talking about dysphoria in the terms of essentially dissatisfaction, mood issues, what have you. So people with this disorder feel they have been assigned to the wrong biological sex. And not always, but a lot of times they would like to remove or alter their primary or secondary sex characteristics and acquire those characteristics typically associated with the opposite sex. Now, another thing that is maybe falling under this, I've seen people kind of argue both ways for this, are people who are non-binary, who just feel like they don't have a biological sex. Some people will classify them under this as well. The other side note is that technically anyone can be gender dysphoric, right? So like, even though I identify as female, right, and I use she, her pronouns, like it is possible that I have a day where I'm just really dissatisfied with being a woman, right? Because being a woman sometimes sucks in our society, right? So you wouldn't be diagnosed with the disorder, but you could experience gender dysphoria no matter who you are. The DSM-5 categorization of disorder is controversial. Many people believe that transgender experiences reflect alternative, not pathological ways of experiencing one's gender identity. Others argue that gender dysphoria is in fact a medical problem that may produce personal unhappiness. Again, trans advocates I've talked to like that this exists because it helps people get the medical treatment they need because they have a diagnosis. Because that's the way our insurance policies work, is that you need a diagnosis in order to like undergo hormone treatment or you know, some sort of surgical procedure. So for that reason, with our current insurance system, I think it needs to stay. But I think it's problematic that we're pathologizing people who are trans, basically. Men who have this disorder outnumber women 2 to 1. And I don't know how much of that is completely accurate or whether we just don't see women, you know, sort of coming out as trans more often. This might change over the next few years, I think, as people become more willing to talk about these issues. People with gender dysphoria often experience anxiety or depression. They may have thoughts of suicide. They usually feel uncomfortable wearing the clothes of their own sex, and they may cross-dress. Again, this is distinctly different from that transsexual fetishism. There is no sexual arousal related to it. It's just, in fact, just to like feel comfortable in their own bodies. They feel like they need to do this. The disorder sometimes emerges in childhood and then sometimes will kind of go away during adolescence. They don't necessarily think that that means that it was like a fad or a trend. It just could be that particular person found a way to resolve their dysphoria while existing in a body that's, you know, not congruent with what they initially felt. But in most cases, we see this into adulthood and people seeking treatment. Several theories have been proposed, but research is limited and generally weak. It seems like there are probably biological genetic factors here, and maybe linked to the hypothalamus. And some adults with this disorder will change their characteristics by way of hormones. Others will actually have sexual reassignment surgery, or actually, I really like the way it's being described recently, which is sexual confirmation surgery, because you are confirming or changing your body to the way you feel it should be, right? So again, this diagnosis exists to help people get treatment. And I'm going to show you all a clip. Oh, here is the actual criteria. Let me touch on those real quick. But so you've got this inconsistency with your assigned gender and your experienced gender. It's got to last 6 months or more. And you've got to have 2 or more of the following: marked inconsistency between one's experienced gender and their sex characteristics, desire to be rid of those sex characteristics, desire for the sex characteristics of the other gender, desire to be a member of the other gender. See, I also don't like this language because it assumes there are only 2 genders, and we know that's not true anymore, right? To be treated as a member of the other gender, and conviction that you have typical feelings and reactions of the other gender. So it includes significant distress or impairment. So I'm going to show you all this clip, and I'm going to preface it by saying this movie is problematic because they had a heterosexual cisgender. And if you're not familiar with the term cisgender, it is someone who's not transgender. So most of us identify as cisgender here. It includes a person who is a heterosexual cisgender woman playing a trans woman, which is problematic. A lot of people are trying to move away from this now and actually have trans people represent trans people, people like Laverne Cox, right? But I'm going to show this clip just because this dinner table scene I'm going to show you will illustrate a lot of the psychological issues these people experience, and rejection by, say, their family, for example. So let me do a new screen share. And just to give you some background for people who have not seen this movie, so Felicity Huffman's character is the trans individual. She is going on a cross-country road trip to go get her surgery. And so she has, on the way, discovered she fathered a child. And so he's with her. And then the other people around the table are her family of origin, who are of varying degrees of acceptance of her. So the last statement is to the fact that the mom is going through menopause, so she has to take estrogen supplements, and so does the trans woman. So I didn't give you all the context, like the sister is deciding she's Jewish, so that's causing problems too, and obviously a very loosely Christian family. So again, problematic in who played the character, but I think the script really gets at what these issues are like for these individuals, especially when their families of origin won't, acknowledge their transition or, accept in any way, shape, or form what they're going through. That's a big part of the gender dysphoria, to be perfectly honest, is not having people accept you. And like she said, you never had a son. Always felt that she was born in the wrong body. Alrighty, so we have about 15 minutes or so to start our schizophrenia lecture. So I'm going to pull that up. Let me just get the chat and all that good stuff going. And so schizophrenia is, again, something that's a lot more rare than it's actually portrayed in the movies. It's not as common as people tend to think. But when it does occur, it is as problematic as it's portrayed in the movies. It's very disruptive to people's life. And, even with treatment, sometimes it's problematic, although we do have treatments that work pretty well for it now. When you do the clinical choices, one of the videos for the schizophrenia one you'll watch is actually a clip Anderson Cooper did, where he wore headphones that simulated what it's like to hear voices. And, he did that for probably like an hour, and he just talks about how much he hates it, right? And so imagine like that was 24 hours a day of your life. So schizophrenia is a disorder of psychosis, and psychosis is a state of being profoundly out of touch with reality. It's the ability to perceive and respond to the environment is significantly disturbed, and as a result, your functioning is impaired. Psychosis is kind of like saying someone has a fever. So if you say someone has psychosis, we don't know why. Right, like if I said I have a fever, it might be because I have the flu, because I just got my COVID vaccine, right? Because I have strep throat, right? There's a whole host of reasons. And psychosis is the same thing. Oh, I see a question from Ryan. Do you think transgender, assigned gender male, but identifies as women should be allowed to fight in the women's UFC? Oh, this is a really good question that's actually up for debate in terms of sports all over right now. And this has always been an issue, even before trans issues really came to the forefront of people trying to decide who is feminine enough to compete as a female. So as far as I know, the IOC still employs gender testing. That's the International Olympic Committee, where they'll do blood tests. And if you have too much testosterone, or your XXY, say, they will try to say you're not actually a woman. But the thing is, those people aren't trying to cheat, right? They just didn't know that. And so I think that trans women may be the same way, right? That people are going to assume they have some sort of advantage, possibly, right? But they're also often taking hormones that might make training actually more difficult. I think this is an issue that we need to resolve in general. The fact that we just have men's and women's sports creates a lot of issues, right? With people who are non-binary, people who are trans, by which sports are considered the marquee sports. So I don't know how much anyone saw of this, but the NCAA basketball tournaments, the men's team had a full weight room and the women's team had like a stack of yoga mats and some dumbbells. Like it was absurd. So, we tend to devalue women's sports and then say it's because they don't get the attention of men's sports, but like how can they if like that attention's never given the opportunity to give. So yeah, I think there's a lot of really complicated issues in my answer to that question, Ryan, that I think we have as a society have to reckon with over the next few years, right? So yeah, I would say I think that we should allow people to engage in sports if they are interested. We certainly shouldn't force them to do it, right? But yeah, sort of figuring out how to navigate that is still an issue. And again, still an issue for people who identify as female, who seem outwardly to be female, but then again, when they do these blood tests, they're like, oh, you have a lot of testosterone, or oh, you're XXY, and they literally have no idea. So we also need to revise our really limited view of biological sex as well as gender. So biological sex is not as black and white as we think it is. And I think that because our world is really constructed like it is, it's problematic. Yeah, that was a little tangential, but good question. And my answer was tangential, not your question. So yes, back to psychosis. So just like, we don't know why you have a fever, we don't know why you have psychosis if you have psychosis until we look into it more. So it could be caused by a brain injury. It could be substance induced, right? So if you take certain hallucinogenic drugs, right, they're essentially inducing psychosis. It can be in the context of a mood disorder, but typically when we think of psychosis, we think of it within the context of schizophrenia. The two main symptoms of psychosis are hallucinations and delusions. Hallucinations are false sensory perceptions. So abnormal sensory experiences such as hearing or seeing non-existent things. And as we go through this lecture, you'll see we can have them in any of our senses. And then delusions are fixed false beliefs that are often bizarre or just, don't jive with reality. We'll put it that way. So again, psychosis is this broad term referring to hallucinations and or delusions. And schizophrenia is a type of psychosis that also has disturbed thought, language, and behavior. And both schizophrenia and psychosis are heterogeneous, which means that people who have either of those things can look really different than someone else who has the exact same label. And in fact, gosh, it might have been 6 or 7 years ago now, a study came out that suggested that schizophrenia might be 8 distinct genetic disorders that we've lumped under one thing. So, we have a long way to go to figure this out. So again, here might be more of a substance abuse psychosis and, the antacid, right? So there are other ways you can do this. So people with psychosis have not always been regarded as sick. In certain cultures, people who have psychosis have been viewed as creative, spiritual, wise, or enlightened. In the US in the 1960s, certain theorists actually romanticized schizophrenic psychosis and a heightened appreciation of reality or an effort to be maybe sane in an insane world. In the Western scientific medical tradition, psychosis has generally been regarded as a symptom of illness, however. So how have we classified it? Well, really interestingly, schizophrenia is actually the disorder that really encouraged classification more than it was inspired classification more than anything else. So beginning in the 1800s, people started to try to classify and describe disorders in general, but most particularly psychosis. So in 1923, Emil Kraepelin coined the term dementia praecox. And so this was an early term used for schizophrenia, and it was characterized by global disruption of perceptual and cognitive functions, early adult onset, and a progressive deteriorating course. And unfortunately, these things are often true, although some of the treatments we do have can stop that deteriorating course. So in 1938, Bleuler, I always pronounce his name wrong, it might be Bleuler, but he coined the term schizophrenia. So he was the first one to use that word. So he thought Kraepelin's classification and description was too narrow because it doesn't always onset in early adulthood. And, again, we don't always see that gradual deteriorating course. So he focused on the symptoms that are now known as the 4 A's of schizophrenia. The first is extreme ambivalence, a paralysis of the will, sort of not being tuned into what's going on around them and kind of not caring. The second is abnormal associations and thinking. So this is where those delusions and hallucinations come into play. Disturbed affect. So people's emotional reactions when they have schizophrenia are not appropriate. So sometimes, for example, they would laugh when something is supposed to be sad, or sometimes they just have what we call flat affect, where they just don't show any emotions. And then the term autism was used here, and not in the way of the way we use autism now in terms of a neurodiverse diagnosis. Autism here was used as a term to describe a withdrawal into fantasy instead of focusing on reality. So Bleuler coined this term to describe schizophrenia, and then it was later applied to the childhood disorder that we now recognize. So he named this syndrome as schizophrenia, which is a disorder marked by psychosis and this decline in adaptive functioning. All right, so currently we think about there being 2 types of symptoms. So they're the positive symptoms. And just like when we talked about positive versus negative reinforcement, these do not mean these are great symptoms to have. They just mean there's things that are added onto quote unquote normal behavior. So pathological excesses, exaggerations, or distortions from normal functioning. Or the presence of something that's normally absent. So this is again where the delusions and hallucinations would come into play, but also something we'll talk about in a few slides, probably won't get to it till Thursday, looking at the time, but is disorganized speech, thought, and behavior. The part that often gets overlooked, especially in media portrayals of schizophrenia, are the negative symptoms. And these can be just as disturbing, distressing to the person, problematic in interrupting their lives. So these are symptoms that represent pathological deficits. Again, think of it as we're taking something away that would typically be there, the absence of functions that are normally present. So this will include things like flat affect, so loss of affect, loss of motivation. Some severe forms of schizophrenia, there will just be a lack of speech, like they will not speak. So the current diagnostic criteria include both positive and negative symptoms. And I'm actually going to stop there for the day so that we can take our time with the diagnostic criteria on Thursday. We will get through the rest of this PowerPoint, no problem then, and you'll have all the info you need for your exam a week from today. So thank you for your excellent questions today. This is like one of my favorite parts about teaching abnormal is you all make me think of things that I might not even have the answer to. So I love that. So thanks for firing those away. So I'll stick around for a couple minutes like I usually do if anyone has any questions or concerns. If not, I will see you on Thursday.